Alright, so we're back and we're going to talk about some infections of the bone and joint, and I'm just going to forewarn you if you hear any noises in the background. It's the 4th of July, so there's some fireworks going off. Alright, so what are we going to talk about today? We're going to talk about osteomyelitis, septic arthritis, which is divided into the non-gonococcal and gonococcal types, Lyme's disease, and gas gangrene. So just a review of the bone structure. Of course, this is the femur. And we have cartilage which surrounds the bone anywhere it comes in contact with a joint. We have spongy bone, compact bone, and then that's surrounded by the periosteum. So this is just a sort of a cross section here, a coronal cross section of the bone. We also have on the most inner part we have a medullary cavity. In most long bones, there's bone marrow, and so the medullary cavity holds that bone marrow, which of course is responsible for creating new blood cells. Okay, now that we've talked about that, let's talk about osteomyelitis. So osteomyelitis, we can break it down into the root words, osteo meaning bone, myelo meaning marrow, and itis meaning infection. So it's an infection of the bone and the marrow. It doesn't have to be both, it could be one or the other. Generally it includes bone though. So this is infection and inflammation of any part of the bone structure, including the periosteum to the marrow cavity. There tends to be a preponderance in the lower extremities, and the offending agents, Staph aureus is the single most common, but most cases, many cases, are polymicrobial. And so when we treat osteomyelitis, generally we have to use empiric coverage, covering staph, strep, and gram-negatives. Risk factors for osteomyelitis include IV drug use, because we're introducing external bacteria into the system, diabetes mellitus, surgery, prostheses, and sickle cell disease. So there's 3 different mechanisms to consider when we consider how you can get osteomyelitis. The first is the acute hematogenous mechanism, and that would be due to spread from the blood. So you have infected blood, septicemia, you have a bacteria in your blood, perhaps you have symptoms from that, perhaps you are septic, or maybe not. But you have bacteria in your blood and it spreads to the bone, plain and simple. The most common organism in acute hematogenous osteomyelitis is Staph aureus, and usually when you have osteomyelitis from the acute hematogenous route, it is a single organism, and that organism is Staph aureus. There's also post-traumatic / device-related osteomyelitis, and this is due to trauma or the collection of bacteria on a prosthetic device or on the bone itself. And generally this tends to form a biofilm. And then vascular insufficiency is secondary to breakdown of bone structure, and this will result in a direct infection. So 3 different manners. And you can see that IV drug use would lead you to acute hematogenous, because IV drug use would introduce skin flora into the bloodstream. Prostheses would lead you to device-related, and diabetes mellitus would lead you to vascular insufficiency. So those are why those risk factors come into play. So as far as the acute hematogenous, as we mentioned, it's due to spread from the blood, which is septicemia. It doesn't mean you're necessarily septic, doesn't mean you even had symptoms from that spread to the blood. A lot of people have bacteria in their blood for a point in time and they don't even have symptoms. So you don't have to have septic shock to have septicemia. It's just due to spread from the blood into the bone. And most commonly it's from a single organism, and that's Staph aureus. This predominates the pediatric cases, so usually when you have a child with osteomyelitis-like symptoms, it's going to be from acute hematogenous spread. And it tends to affect, in children, it tends to affect the long bones, and that's usually going to be the tibia or the femur. In adult patients who get acute hematogenous osteomyelitis, it tends to affect the vertebral bodies, usually in the lumbar vertebrae. For post-traumatic and device-related osteomyelitis, this can spread from septic arthritis, so that can be considered a post-traumatic arthritis because, or post-traumatic osteomyelitis, just in and of the fact that you have the septic joint breaking down and invading the bone cavity. Or if it's from a prosthetic device, there's usually biofilm formation, so that will occur over a long period of time. Vascular insufficiency, as we mentioned, is secondary to a breakdown of bone structure. This is almost universally in older patients, and as mentioned, diabetes mellitus is the major risk factor here. So this is just good to remember for the pathophysiology, but in general, we're going to treat all these patients the same way. But this will help you remember sort of what the risk factors are and why we treat osteomyelitis, how we treat it. Okay, so the symptoms for osteomyelitis. Generally, the patient will present with local pain. Of course, it's going to be pain over a bone, so this isn't going to be abdominal pain or pain over the fatty muscular area of the leg. It's going to be over a bone. There'll be some swelling and redness, usually some heat. You'll have your 4 cardinal symptoms of inflammation. And generally, there'll be some constitutional symptoms as well, low-grade fever, chills, fatigue, lethargy, etc. On physical exam, you'll have a slightly decreased range of motion at the affected site, which is usually proportionate to the pain. There'll be point tenderness, and like I mentioned, cardinal signs of inflammation, which may or may not be there depending on the course of the illness. If it's early on, you may not have all 4, but later on you will have your swelling, your redness, your pain, and so forth. So diagnosing osteomyelitis can be difficult because if it presents early, the first test that you're going to do will come back negative. So in a clinical setting, the first step is going to be to get an x-ray. Why? Because patients who are later on in their osteomyelitis will show a positive result on their x-ray. But it's important to remember that if a patient shows symptoms of osteomyelitis, a negative x-ray does not rule out osteomyelitis. So you get a lot of false negatives here because it can take up to 2 weeks for the x-ray to show signs of osteomyelitis, which would be a decalcification of the bone. So ultimately for diagnosis, if the patient has not had the symptoms for 2 weeks or more, then a CT bone scan or an MRI are going to be the best initial test to arrive at your diagnosis. Even though clinically you may have seen an x-ray be the first test that your attending did. The CT bone scan or MRI early on in the course of osteomyelitis, if the patient hasn't had symptoms for very long, that's going to be the best initial test because it's guaranteed if it's less than 2 weeks, there's a high probability that you're going to get a false negative x-ray. And so that's to detect early osteomyelitis. The most accurate test is a bone biopsy with culture, and you absolutely have to get this if you suspect osteomyelitis. So generally, you're going to get this after your CT bone scan or your MRI comes back positive, and you're going to have to get a bone biopsy with culture because we're going to treat the patient, but ultimately we want to know what the bug is that is causing the osteomyelitis. So in case our empiric therapy doesn't work, then we can do sensitivity tests. And not all, you probably, if you've watched these infectious disease lectures so far, you've probably noticed that biopsy is always the most accurate test in most infectious diseases. And that's true, but it doesn't mean we always do the biopsy in the culture. In osteomyelitis, we absolutely have to do a biopsy in culture. Okay, so another thing that you can see with osteomyelitis is a sinus draining tract, and this is what this really is just a tract through the skin that's formed from the inflammation, and pus from the actual infection will drain out of this from the skin. So this is, you've got your osteomyelitis in here, and then this sinus drainage tract here is how the pus is actually getting out. And this is an x-ray of the same patient. This is obviously very progressed osteomyelitis because they have a sinus drainage tract. That doesn't come right away. So this is somebody who's let it go. And then here we have CT and then an MRI. And then this is afterwards. The patient had rods and pins placed. Okay, so in children, antibiotics alone will usually suffice. So once you've made your diagnosis, for children, antibiotics alone are usually going to be enough. But for adults, antibiotics and surgery are going to be both necessary. So children, antibiotics alone, adults, antibiotics and surgery. We're going to start empiric therapy right away before we even know what the bug is, so before we've even gotten the results back from the culture, and we want to cover Staph aureus and gram negatives. If the disease occurred in the hospital, then we want to cover MRSA. For covering the staph, we're going to use an anti-staph penicillin, or what is otherwise known as a semi-synthetic penicillin, and that could be oxacillin or nafcillin or difloxacillin, or we can use an anti-MRSA agent in its place like vancomycin and linezolid. We also have to cover gram negatives, so we can use either an aminoglycoside like gentamicin and amikacin, or we can use a third-generation cephalosporin like ceftriaxone or cefotaxime. So an anti-staph or anti-MRSA plus an aminoglycoside or cephalosporin. Okay, so septic arthritis. So this is an infection and inflammation of the synovial fluid, which is the joint. So this is going to cause joint pain. And so up until now, we've been talking about osteomyelitis, which is inflammation, pain over the bone. This is going to be inflammation inside, pain over a joint. So the offending agents here are really quite the same. Staph aureus predominates. However, there is a septic arthritis that's caused from Neisseria gonorrhea, and so that's going to warrant special attention. And then, of course, there are others, but Staph aureus is the most common. Risk factors include anything that damage the integrity of the joint, so rheumatoid arthritis, osteoarthritis, anything that damages the integrity of the immune system, so diabetes mellitus, liver disease, cancer, immunosuppression, injury to the bone or joint, and then as far as the gonococcal septic arthritis, of course, sexual activity is going to increase your risk because that's the primary route of acquiring Neisseria gonorrhea. So, as you've probably noticed, we divide this into two categories for consideration. Septic arthritis is divided up into non-gonococcal septic arthritis. This tends to be in the predominantly older patients. It tends to stay in one joint, like the knee, and the knee is the most common joint that it will present in. Gonococcal arthritis tends to present in younger patients in their 20s, 30s, 40s, and it tends to be more of a migrating arthritis, so it can occur in different joints at different times. The hands are a particular place that this presents, but it can present anywhere. It's also associated with tenosynovitis. So tenosynovitis means inflammation of the joint and the tendon. So this can actually, gonococcal arthritis can actually cause a pain that's not only in the joint, but runs up the course of the tendon. And so that's something to keep in mind with gonococcal arthritis. So let's focus on non-gonococcal arthritis for now, and the offending agent is most commonly Staphylococcus aureus. So the history, most of these patients will have had an episode of bacteremia, and that's because one of the easiest ways for arthritis, for septic arthritis to occur is from the blood getting into the joint, because what is synovial fluid? It's an ultrafiltrate of the blood. So if there's bacteria in the blood, there can be easily bacteria in the synovial fluid. Another joint disorder is certainly a predisposing risk factor. So rheumatoid arthritis or osteoarthritis, or any factor that weakens the immune system like steroids, HIV, and cirrhosis. The symptoms are going to be acutely painful, tender, swollen, erythematous, warm joints, which may have quite a large effusion. Chills and fever are often present in non-gonococcal arthritis. It will usually be a low-grade fever, but fevers can run up to 102, 103 degrees. And then the knee is the most commonly affected joint. Hip, shoulder, wrist, and ankle are also seen. So to diagnose non-gonococcal arthritis, whenever you have a joint that has an effusion, the first step should always be a synovial fluid analysis. And that also happens to be the first diagnostic step. There is a lot of things that can cause a painful effused joint, gout being one of them. But for all of them, a fluid analysis is going to be, a synovial fluid analysis is going to be the best diagnostic first step. And this also happens to be the most accurate test. When you analyze the synovial fluid, a white blood cell count of greater than 50,000 microliters is present. The empiric therapy for non-gonococcal arthritis is going to focus on the most common causes, staph being the number one cause, strep, and gram-negatives. Usually you're not going to find an organism with gram stain. It's usually going to take culture, but if you do find an organism on gram stain, you can just simply target that particular organism. But most of the time we're going to have to use empiric therapy focusing on staph, strep, and gram-negatives. So a semi-synthetic penicillin or an anti-MRSA agent will cover staph and strep. So oxacillin, nafcillin, or if we're suspecting MRSA, then vancomycin or linezolid, and those both would cover any of the strep causes as well. To cover the gram-negatives, we use an aminoglycoside or a third-generation cephalosporin. So this is basically the same way we treat osteomyelitis. And then we'll adjust the treatment regimen when the culture results become available. So how about gonococcal arthritis? So the offending agent here is Neisseria gonorrhea, and the history, generally these patients will be younger. A sexual history will be present in these patients, although sometimes they might not admit it to you. Sometimes there'll be a history of recent urethritis or cervicitis, and like I said, it's more common in younger patients. It's also more common in women and more common in men who have sex with men. That's simply because gonorrhea is more common in those patients. So the symptoms include acute onset polyarthritis. So these are patients that, unlike the non-gonococcal patients, these patients will usually point to multiple joints where they've had pain. So wrists, knees, ankles, and elbows are most common. Fever is less common in gonococcal arthritis. Neisseria gonorrhea itself, the bacteria, doesn't cause as much of a pyrexic reaction, so don't expect to see as high a fever. Skin lesions are really going to point out gonococcal arthritis, though. So when you have arthritis, a polyarthritis in a younger person, and they have skin lesions, definitely that should point you towards gonococcal arthritis. Now, arthritis plus a rash, not skin lesions, could point you towards Lyme disease, but that's going to be like Erythema migrans, that the target lesion. With gonococcal arthritis, you'll have small purpuric pustules over the extremities, so over the arms or the legs. And I'll show you a picture of what that looks like. Also, as I mentioned, with gonococcal arthritis, these patients tend to have not only pain in their joints, but the pain will run up their tendons. The diagnosis, again, here for gonococcal arthritis, like in any septic arthritis, the best first step and the most accurate test is going to be a synovial fluid analysis with culture. Again, here the white blood cell count will be 30 to 60,000 microliters. And you should also, on these patients that you're suspecting gonococcal arthritis, get a blood culture and cultures for gonorrhea. And the places you're going to swab are the urethra, the cervix, the rectum, and the pharynx. And the reason for that is because gonorrhea Neisseria gonorrhea may not culture, and it may not show up in the synovial fluid, but your cultures for gonorrhea or your tests for gonorrhea in the urethra, cervix, rectum, pharynx can come up positive before your synovial fluid will. So a lot of times it's useful to test for gonorrhea in those non-synovial spaces in addition to getting your synovial fluid analysis. But all the time, if you're suspecting gonococcal arthritis, you always have to get a synovial fluid analysis with culture. It's also useful to get an echocardiogram in these patients because patients with gonococcal arthritis are predisposed to endocarditis. So you'll want to rule that out. The treatment here, once we've confirmed that it's gonococcal arthritis, we simply treat it with a third-generation cephalosporin, particularly ceftriaxone is the most commonly used therapy. Patient education about safe sexual practices would be useful as well. And generally, there's a pretty dramatic resolution of symptoms in 1 to 2 days. So here's some of those papule sort of vesicular lesions. They're about, like I said, about 5, 6, 7 millimeters in diameter. They occur on the legs and on the arms. Usually there's not more than a dozen of them. Okay, Lyme's disease. So Lyme's disease was first recognized in a town called Old Lyme, Connecticut, and this is a picture of the town hall there. Or I don't know, this might be a church. But anyhow, Lyme's disease is a polysystemic, multiphasic disease caused by the spirochete Borrelia burgdorferi, and it's carried by the Ixodes tick. So this is caused by a bacteria, but it's a bacteria that's transmitted by a tick. And it's prevalent in the eastern and midwestern U.S. So here's a map. The northeastern U.S. is it's very abundant. You can see particularly here in New England and in New Jersey. It's also common in the upper Midwest, for instance, where I'm coming to you from, which is central Minnesota and Wisconsin. And it also has a prevalence area in the redwood forest area of California. So often these patients will present with a fever and a rash. That's not an uncommon presentation, but the classical rash that you will see with Lyme's disease that will really set off your radar is called Erythema migrans, which first appears at the point of the bite. And what Erythema migrans is the classical target rash. So, as mentioned, Lyme's disease is a multiphasic disease, so it occurs in 3 distinct phases. The first one being the early localized stage. So a lot of patients do present in this stage because it causes that somewhat alarming Erythema migrans rash, and there is a public awareness now about Lyme's disease. So in the early localized stage, within the first month after the bite, the symptoms will be fever, the rash, and then asymmetric myalgias and arthralgias. So not only could these patients have joint pain, but they can also have pain in their muscles as well. Several months after the bite, if the patient hasn't gotten treatment or hasn't realized that they have Lyme's disease or have anything that needs to be treated, if they haven't presented for anything, this can present with more neurological symptoms. So meningismus, which is your meningeal irritation symptoms, stiff neck, Koenig sign, Brzezinski sign, so forth, a headache, a unilateral facial nerve palsy, which is like a Bell's palsy, which would be like a drooping of the eyes and the cheek and the lips, and chronic fatigue. And then the late persistent stage, which usually does not develop because usually patients will have came in by this point, will present with severe joint effusions and psychiatric disturbances. Generally on the USMLE, this will be given to you as an Erythema migrans patient or as a patient with meningitis that does not have a septic meningitis, but in fact has an aseptic meningitis. Okay, so here is a picture of Erythema migrans. I've got a bunch of pictures of Erythema migrans to show you because not all of them look the same. So usually there's this outer periphery of redness and then sort of an inner clearing. and then there'll be some irritation around where the bite was. Now, generally the patient was only bit in one place, but you can get multiple of these Erythema Migrans rashes even though you only were bit in one place. So this is likely where the patient was bit, because usually there's this target spot around the bite, and then the central clearing, and then more erythema around the periphery. Here's another one. This patient may indeed have been bit in 2 spots, but this is a very large lesion here, so they can get to be quite big. And this one's a very faint one. But you should definitely keep an eye out for this, particularly in the months from April to October, especially if you're in the endemic areas. If a patient presents with joint pain, and particularly if it's a younger patient who has an avidity or a history of outdoor activities. So to diagnose Lyme's disease, it really depends on the stage and on the symptoms. So if the patient has Erythema migrans, if they have that rash, and you see that rash, and the patient is in an endemic area, or they have been to an endemic area, then you can just go ahead and start treatment immediately. You can make a presumptive diagnosis of Lyme's disease. So, for instance, for me, living in Minnesota, if a patient came in here with Erythema migrans, I would go ahead right away and treat them for Lyme's disease. Particularly now, it being July, people are getting outside. Now, if it were December and I were living in Colorado or Utah, where the prevalence is very low, then simply Erythema migrans, I would not necessarily treat them for Lyme's disease. Now, if the patient presents with meningismus, then of course we're going to get a lumbar puncture and a CSF analysis. And that's not necessarily thinking the patient has Lyme's disease, that's thinking the patient could have meningitis. Now, when you get the lumbar puncture and CSF analysis back, and the patient indeed has a lymphocytic meningitis, which would be consistent with either a Lyme's meningitis or a viral meningitis, then that's an indication to get a Borrelia ELISA or Western blot. So any patient with neurological symptoms or a patient with meningismus that winds up showing lymphocytic meningitis, they're going to get a Borrelia ELISA and Western blot. And Borrelia ELISA and Western blot is the most accurate test for testing for Lyme's disease, but it is expensive, so we prefer not to do it right away. So those neurological symptoms are meningismus, facial palsy, peripheral neuropathy, and then a lumbar puncture, CSF analysis that shows a lymphocytic meningitis. There are Borrelia serology tests, but there are a high rate of false positives and false negatives. So Borrelia serology, if it's the only choice you have, go ahead and choose it. Some physicians will perform it in hospitals or clinics, but it is not the most accurate test, nor is it the best initial test ever. So that should be kept in mind. But if it's the only choice you're given on the USMLE, if you're not given Borrelia ELISA or Western blot, and the patient doesn't fit into any of these categories, then you can go ahead and answer that. But do remember that if the patient has Erythema migrans and they're in an endemic area, you're going to go ahead and start treatment immediately. For Lyme's disease, cultures are not used. So this is a sort of a black sheep out of the infectious diseases. Cultures are not useful for Lyme's disease simply because Borrelia doesn't culture very well. So the 2-stage testing is the most accurate test, but like I said, it's not necessarily the best first step in diagnosis. The treatment for Lyme's disease, the standard is doxycycline, and that's going to be used for most adults. There are exceptions. You shouldn't use amoxicillin in women who are pregnant or breastfeeding because it will go through into the embryo, and it will go into the breast milk. So we use amoxicillin for pregnant and breastfeeding women. We also don't use doxycycline in children less than 8 years of age, so we will use amoxicillin in children. But doxycycline is the standard of treatment for most adults. Don't be surprised if you get a question on the USMLE that gives you a 6-year-old patient that has Lyme's disease, and it asks you how to treat them, you're going to treat them with amoxicillin. So while you may drill into your mind Lyme's disease equals doxycycline, that's fine. Just remember, there are exceptions. Doxycycline cannot be used in pregnant women, breastfeeding women, and in children less than 8 years of age. Now, there is an exception, and I'm kind of going off into a tangent here, but when the patient has Rocky Mountain spotted fever, which we'll talk about in a different section, in that case, yes, you do use doxycycline in children less than 8 years of age because amoxicillin wouldn't be effective. So, but doxycycline do not use in children less than 8 years of age. Patients with severe Lyme's disease, particularly Lyme's disease that's confirmed where the patient has altered mental status, severe joint effusions, those patients are going to get IV ceftriaxone. But that's not going to commonly come up on the USMLE. I apologize for these fireworks, by the way. In addition, with Lyme's disease, you should also check the CBC if you've confirmed Lyme's disease. The patient should never be anemic with Lyme's disease. And the reason that I bring this up is because Lyme's disease and babesiosis is carried by the same tick, the Ixodes tick. So you should always check the CBC on a patient with Lyme's disease. If they're anemic and thrombocytopenic, that is suggestive of co-infection with babesiosis, and they would need additional treatment for that. All right, finally, we'll come to gas gangrene. Gas gangrene is an anaerobic infection of the muscle tissue itself, generally due to a penetrating trauma or a war injury. So this is very uncommon in the United States, usually because patients get to health centers pretty quickly if they're in car accidents. It can also be seen on the war field, but again, this is more like a Civil War era thing. But it is important to talk about because it does happen occasionally. So the anaerobe Clostridium perfringens creates toxins, and those toxins cause necrosis of muscle cells, and that necrosis is going to lead to swelling and ultimately sepsis. And this is a surgical emergency. So patients who have symptoms suggestive of gas gangrene will usually have a history of traumatic injury. They could also be post-operative. So that would be a iatrogenic cause of gas gangrene. That would be a bad thing if you're looking at keeping your practice. Symptoms for gas gangrene are going to be very, very severe, localized, and steadily progressive pain and edema. Generally, it's going to be pain that's way out of proportion to how the extremity looks. There'll be generally some discoloration of the skin, bronze to blue, and crepitation, which is kind of that sound that you make with your fingers if you've ever played with that bubble wrap stuff. And then systemic symptoms may occur late in the disease, which would include renal dysfunction, an elevation in creatinine, altered mental status, and finally hemodynamic instability. Generally, when the patients get to this stage, usually their outlook is pretty grave. For diagnosis, because this is such an emergency, we're not going to do much of a workup. If the patient has this steadily progressive pain and edema, particularly if they have discoloration or crepitation, you're going to be getting this patient in the OR right away. If you have the option, then you can do a gram stain of the infected exudate, which would show boxcar gram-positive rods, and that would confirm the diagnosis of gas gangrene or infection with Clostridium perfringens. Otherwise, this diagnosis should be a clinical diagnosis because the ramifications are so grave. So it can be confirmed during surgical exploration with a biopsy, and you usually will get that, but you should be getting this patient into the OR right away. And the gram stain will show gram-positive rods without white cells. And the reason for that is because the infection here is not accompanied with inflammation. It's an infection that's caused by a preformed toxin. And the therapy is going to be generally how we diagnose the patient, and that's with immediate surgery, so surgical debridement, and we're also going to treat them with antibiotics, IV penicillin, high dose. If the patient is sensitive to penicillin, we can give them clindamycin. And that's the end. Sorry for the fireworks.